Paul, for the kind introduction. I'll share with you a little bit my personal concepts and concepts that grow over the years on how to improve ACL surgical outcome and indications for anterolateral reconstructions. We are recently, I think since 2013, really came up in the literature. I was part of that reason on the anterolateral reconstruction. This is my disclosure slide on the topic. Now, I'll start with some statements, and some of these might be bold, but I am truly convinced that some knees are just prone to have an ACL injury while others are not, and the athletes are a different animal within that comparison. But yesterday we did a 14-year-old kid with an ACL revision. So there must be some factors that actually make you prone for an ACL injury and different factors that make you not prone for ACL injury. And understanding these factors probably will make us better surgeons at the end of the game. Some variables we now are really aware of, and this data, this literature, this research really came on only the last years. We're doing ACL reconstruction for more than 30 years, but only recently there's more and more data showing why some patients have higher chances for ACL injury. We know that the vast majority is, of course, a non-contact injury, meaning it's not caused by somebody else. It's within your body that something happens. Poor neuromuscular control is one of those typical physiotherapist and physical medicine approaches. We, at least as a surgeon, I still don't know what makes this control so important, but it is definitely one of the reasons why some patients have higher chances for ACL injury. I am a true believer also that quad-dominant patients most likely will benefit more from an extensor apparatus graft than a hamstring graft in these patients. The difficulty is identifying which patient is quad-dominant. We see patients with higher peaks of ACL injuries at a younger age, and these are the athletes that are just not making it, but just have that fatal injury prior to their entrance at the top level of their sports. Of course, genetics and bad collagen, hyperlax patients have a higher tendency to have an ACL injury. Gender is part of the equation. Of course, the type of sports. Soccer, for example, is a very high-risk sport versus other types of sports. So that is some of these variables that are associated. We also know nowadays that if you look to the knee itself and to the bone itself, the anatomy of the bone, there are certain indications that some of these designs are faulty, are flawed, and therefore have a higher risk. And number one is high tibial plateau slope. And we came across this when we entered this area. In the Middle East, the average patient had a significantly higher slope than the Caucasian patient. And understanding that high slope and that tendency that is increased with a higher ACL risk and also with a higher ACL reconstruction failure is crucial to understand why in this area we are confronted with a higher incidence of ACL and why we have a higher incidence of failed grafts also. Narrow notch is typically something more Caucasian. I think many of us know that if you have a trochlear dysplasia, that is associated with a higher incidence of a narrow notch, and that narrow notch is then again associated with ACL injury. That explains why in our ACL injured patients, about 14% has a narrow notch and trochlear dysplasia. Spherical MFC, or spherical mediofemoral condyle, is something you cannot pick up from an MRI, you cannot pick up from a classic X-ray. You have to have a 3D reconstruction, and suddenly you understand that some of these knees really are spherical and therefore a little bit more unstable and most likely more prone for an ACL injury. Short lateral tibial plateau is something that you do pick up on an MRI. If you have an eye for it, if you know what to look for, then suddenly you see that some of these patients have a very big mediofemoral condyle, but a very small and narrow and short lateral tibial plateau. Again, on the rotational point of view, they will shift anywhere. And that's almost like a shoulder with a small glenoid and a big head on top of that glenoid. It's very similar. That causes instability. And spine height also is recently some of these bony variables that has been identified as being associated with ACL injury. There's also soft tissues, of course, and then we go into the collagen business. We know that the ACL has a variable anatomy. Some of them are very small, some of them are very thick. What I now truly understand is if we come in with a graft that is 10 millimeters in size, it's almost always impossible to anatomically restore a footprint that is 20 millimeters in size in your normal human being. So we have 10 millimeter sized grafts for 20 millimeter sized footprints. It's not anatomical reconstruction what we do. we try to be as good as we can with the size of the graft that is available. We can't make a 20 millimeter graft. That's not available in the human body. Lateral meniscus is very important. Injuries to the lateral meniscus, radial tears, root tears are crucial for stability. So if I am confronted with a patient that has a lateral root tear, I will identify that patient as a patient for higher failure after his ACL reconstruction. So inform your patient that that is most likely a crucial injury to that knee, and we have to do whatever is best to improve the outcome. Anterolateral ligament reconstructions or anterolateral ligament has been identified as an important structure, maybe less biomechanical, but more sensatory, like the MPFL, which is a big sensor for rotational instability. Maybe it just not will withhold you from the happening of an ACL injury, but it is an important structure. The capsuloosseous iliotibial band has now been identified as being very important. The deep fibers of the ITB are crucial in rotational instability. And of course, recently by Dr. Landreau, the condylar strap, which is an extension of that iliotibial band, posterolateral structures of the knee, and that really causes a condylar strap for rotational instability. These are some of the videos that we have, but I will move quickly to them. So the conclusions is a number of these distinct intrinsic and extrinsic risk factors have been identified recently, and they explain to me why a specific patient and or a specific knee morphotype is prone for an ACL injury. So look for it. It will make you smarter in your decision making towards which kind of ACL reconstruction and why that patient failed. Understanding why the patient fails is crucial in understanding the results that we publish. Not every ACL publication is on the same sports, on the same patient population. It's all over the place, it's scattered, and we are comparing apples and oranges all the time. And you have to be aware that we need to really identify the patients that are in that study to understand why certain results are different from one publication to the other. That is crucial to make us better surgeons, to make us better physical therapists, to make a better patient at the end of the game. And in order to be successful in ACL surgery, and this is my second statement, we just have to make that specific patient and or the specific knee stronger than the original. If we make it as strong as the original, it will fail again. And I am truly convinced that in most of our patients, if we have a higher risk patient, if we do just an ACL, we will not make that work in the long term. And there are certain data now out there. So being as good as before is actually not just good enough. And that's very important to understand. And it also implies that we must make these knees a little bit more constrained than the original knee, in the high-risk patient knee. And this is where a lot of debate has been recently in the discussions, in philosophies on should we do the anterolateral reconstruction and the ITB and the monoloop and the Lemaire and the Macintosh, because we've seen certain downsides to that type of surgery in certain patients. But I'm truly convinced that if we just make it as good as the original one, then most likely they will fail again if they return to the same level of sports in a number of these patients. Not all of these patients, but a number of these patients with high risks. So how much constraint should we aim for? This is some of the studies that we've done recently, and this is all focused actually on the lateral tenodesis and the ALL reconstruction, which I believe doesn't make really a true difference between them. One is a little bit older, the other one is very recent and a little bit more commercially oriented, but the basic philosophy is the same. If we are discussing this, it's because we are discussing this between two philosophies, two schools of surgeons, one that aim for anatomical reconstruction and one that aim for anatomical reconstruction of the ACL, plus a little more because they believe that that patient deserves a little more because that knee is prone for ACL injury. There is a concern of over-constraining the lateral side. That concern is actually based on the belief that there is a higher stiffness. We have a reduced range of motion if you introduce something extra, which was not there, and there might be an increase of incidence of osteoarthritis. And this is based actually on obsolete surgical techniques, all techniques on isolated extra-articular procedures. So all those surgeries done in the 70s and the early 80s where you had an extra-articular tenodesis done as a sole procedure to address the ACL insufficiency. We saw these complications there. And they do truly limit your rotation in that knee. And these extra-articular procedures are non-anatomical. So lateral tenodesis received a negative connotation back in those days and is still living on within certain surgeries. Now, however, we are very happy that we have over-constraint in certain knees. If you're doing total knees, and I'm also doing total knees, we are so lucky that we have in certain of these indications over-constraint designs or constraint designs, because otherwise we just couldn't make it work. So in total knee arthroplasty, we need to over-constrain, because if you do not address the ligament laxity in that knee, you will loosen up and you will fail again. So we need to constrain those knees better. Also in patellar instability, what we do as a surgeon is we just recreate an MPFL, but that MPFL is 4 times stronger than the original one. Why? Because the anatomy is faulty. That patient has a trochlear dysplasia. The native MPFL fails. If you over-constrain it, or if you increase the strength of that constraint by 4 times, it suddenly starts to work in a number of these patients. So we're very lucky that we have MPFL reconstruction that are stronger than the natural one in these knees. If you look at the ACL, we have to be aware that whatever we do with just ACL reconstruction, there is a failure rate of about or a residual pivot shift in these patients of about 15 to 25%, depending on which literature you're looking for. But overall, if we reconstruct an ACL in a patient and you do an isolated ACL reconstruction, 15 to 25% of your patients will have still a residual pivot. That is considered not a failure. It's just an observation telling you that what we do inside is not just good enough. That was a driver for the double bundle. This is still the driver also for the ACL with extra-articular reconstruction. We also know more and more that if you do an ACL reconstruction, that is associated with a re-rupture rate. Re-rupture rate says 1% every year. In younger patients, it is higher. Why is it higher in younger patients? Because they fail early in the process. If you have a young athlete and he fails this ACL, that means that something in that athlete is wrongly designed, either intrinsic, extrinsic, sports activity, but something is wrong in that patient. The younger patients that we see with trochlear dysplasia are the ones with a higher incidence of the younger the patient that we see with a patellar instability, the more pronounced will be the anatomical variability or the sports he will be performing. Same thing with ACL. If you have your ACL and it fails at 12 years, most likely you will have something that is out of the ordinary and you will have a faulty anatomical design. So I'm a strong believer that you really look into your young patients to identify the patients at risk, and maybe we can do something about that to prevent injuries, or maybe counsel them not to go into certain specific sports. Basically, this has been shown in a very recent publication by the North Sydney group from Australia, looking into survival and associating that with slope and age. And if you look into the survival cut of patients under the age of, these were adolescents, so open physis, under a younger age and with a higher slope, higher than 12 degrees, re-rupture rate of 78%. Only 22% of these patients survived their ACL reconstruction in the younger population. You see them also here. So this just shows you that there are certain things out there that we cannot control with plain ACL reconstruction. We have to do something more. So can we solve this all with an ACL reconstruction as an isolated procedure, or do we have to introduce additional restraints? I am a strong believer that we need to introduce additional restraints in a number of these patients. The question, of course, is in which patient, and that is always the difficulty. That's what typical orthopedics, we always start doing stuff and then we say, but maybe it is more efficient for X patient or Y patient. Anterolateral reconstruction strategies, it's an ongoing debate. It's a very old technique. I call this, for me, this is still a Russian technology. We're flying to the moon. It's still the Russians that fly to the moon. It's old, but it's reliable. It does the job correctly every time. And if it fails, you can bail out. You can redesign the thing, and it's still going to work. So this is very important to understand. This is all reiterations of pretty old stuff out there. There's McIntosh, Lemire, the 72, 75. There's different surgeries prior to that. and this is more than 30 years going on. The monoloop is a very similar surgery. That is a reduction of the Lemaire or the Macintosh procedure. We went from a triple loop, 3 strips up and down, to a single strip of iliotibial band. We're still discussing that we have to do this going under the lateral collateral ligament in order to make it work on a reliable basis. It's a non-anatomical reconstruction of the lateral side. There is no structure there. There's the ALL, which has a different course, but there's otherwise no normal structure there. And it should be combined with an ACL reconstruction inside. So it's an intra-articular procedure and an extra-articular procedure. If you want to see how the procedure works, it's published on View Medi and other media, but it's out there. So we went back to the lab. So this is something that we've been doing for more than 25 years in Antwerp also. This was originally done by Martens. He had very good reasons to do that because he was treating a lot of these soccer players, and he made the transition from the extra-articular procedure towards the intra-articular procedure, ACL, saw an increase in its failure rate, and went back to a combined procedure, and then he was happy. So biomechanically, we started looking into this 25 years after the facts. And this is recent data done at Imperial College with Andrew Amis, and Joris Robrecht is one of the younger junior surgeons that did the cadaver work there. So we try to biomechanically validate what we've been doing for 25 years inside the human knee. It's typical orthopedics, right? It's delayed reverse engineering. Why does it work? Let's have a look. So we did 12 cadaveric studies, or 12 cadaveric knees. We had a sequential sectioning of ACL, anterolateral ligament, and deep ITB, and then we reconstructed ACL, monoloop, and then we took the ACL out. So we had the ACL isolated with the ACL and monoloop, and then we had the monoloop isolated. That's the setup. We looked at anterior drawer at 90 Newton, internal torque at 5 Newton, and a combined, actually pivot shift, so to speak, maneuver on the Polaris optical tracking system. This is very tough data, but you do see an increase of instability if you cut all the structures. So it goes from ACL intact to ACL out, to cutting ALL and ACL, and then to cut deep ITB, ALL, and ACL. So you see an increase in the instability like this, and then what you see is the lower is the ACL intact, and the higher one here is actually ACL graft isolated. What you do see is that the monoloop with the ACL is performing best both in AP and rotational stabilities. So these data really prove that what we do is very close to native ACL. It's actually the closest to native ACL that you can get with this. So biomechanically, we validated that ACL and the addition of a lateral monoloop tenodesis restored native knee kinematics, and this is now up for publication or under review. So you can take slides, but be aware that this is not just cut the whole process of review. But it's very important to understand that we really have data now providing that we can come as close to your native anatomy if you have to address this with a lateral tenodesis in adjunction to your ACL reconstruction. There's also data on why we have to go underneath the lateral collateral ligament, which is, I think, crucial for this type of reconstruction, and I'm talking the monoloop reconstruction, ITB band. We need to go deep with this if you fix it over here on these points. So if you look at this, this is the deep lateral collateral, deep to the lateral collateral, and this is superficial to the lateral collateral. What you see is if you go deep, then it's going to be very stable here, and then you introduce some slackness. So we're not over constraining that knee beyond 30-40 degrees of flexion. That's very important. So there's a slackness, and there's an increase of rotational freedom if you go underneath the lateral collateral. If you go above it with this type of reconstruction and fixation here on the distal femur, then you introduce a different pattern with an increase, and most likely also more constraint and flexions or limitations in flexion, which is very important to understand. This has been published by Kittel and Andrew Amis in 2014. So it's very important to understand that this is this type of reconstruction, actually very close to the monoloop. So monoloop reconstruction, tunneled under the lateral collateral and fixed posterior to the distal femur, shows stability between 0 and 20 and progressive slackness, more freedom once you hit 20 and above. Extra-articular reconstructions above the lateral collateral show an increase in tightness. And this is the conclusion from this type of study. So the indications for lateral tenodesis surgery, according to my experience and also to Philip's experience and the whole group here, is high-grade pivots means that something is wrong in that knee, and it's more than just the ACL. We need to understand that. And so those knees need something extra. High-risk athletes. We perform this type of surgery in high-risk athletes. That means cutting sports, female patients that have general laxity. There's a number of patients where we do this as a primary surgery without any doubt. And for us, it's basketball, soccer players, and professional athletes. Hyperlaxity as such in your normal non-athlete patient population. Specific morphotypes. I now look in my patients. I know the notch is narrow, and I know the slope is high. But I can't change that notch, and I cannot change that slope. But I can do this to accommodate or to compensate for that faulty anatomy. And so those patients are some things that we now pick up and that we didn't pick up previously. And it needs a lot of science and a lot of follow-up to actually prove that we are making the correct hypothetical decisions, but it is truly so that I'm doing this in this patient population with anatomical higher risk factors. Also a one that is very interesting, and we don't have the scientific answer yet, but if you have a lateral tear and it's a root tear, we know you increase rotational instability. We know that root tear is very hard to address and very hard to make it heal surgically, but you can compensate for that rotational instability caused by the loss of the lateral meniscus by adding a lateral tenodesis. It might increase the constraint on that lateral compartment, but we haven't seen that in the biomechanical studies. So for me, that's a clear indication to add something on top of that ACL reconstruction if you have a problem on the lateral meniscus. And of course, 100% of our ACL revisions will have this type of lateral tenodesis. If you look at the visual data that we do have some very nice data showing why it makes sense and why it's actually makes a lot of sense. Is if you look in this knee, this is your native ACL. Look inside the knee and from the outside. This is the lateral collateral. This is the popliteus, which is, I think on the lateral side we have something that we call a tripod. You have the lateral popliteus or the popliteofibular ligament, which is a very important ligament in the knee for rotational or for lateral stability. You have the ALL, which we discovered recently, and then you have the monoloop in that area. This is the course of the monoloop. And now if you make them all disappear, this is the monoloop and this is the ACL. It's actually the same course, the same vector. If you go underneath the lateral collateral ligament, it's the same course, the same vector. It's actually an ACL on the outside of the knee. That's basically it. If you look at MRIs, this is an MRI of one of those patients. This is the lateral tenodesis. I'm putting my arrow there. And that's actually the same spot where the ACL comes out of the tibia on a perfectly sagittal view of the knee. So if you go back, ACL, this is Gertie, this is where the lateral tenodesis starts. And back on the femoral side, this is where it takes a turn. If you position that point, you're going to end up exactly where the ACL is on the inside. So for me, that makes a lot of sense when we're looking into this type of data. There's another video, I think, here. Should have a look where we are. This is a non-reconstructed ACL. This is an older patient, non-reconstructed ACL with just a lateral tenodesis as an isolated procedure, an old one. And you see the same course, but if you see those same points, they actually correspond with your interarticular ACL. That's why it makes such a difference. And that's the same vector as the ACL. This is it, and again, you're going to see where this one ends up in respect to your ACL. That's the ACL reconstruction, and the other one is lateral tenodesis. This is a video, I think, showing you the course underneath the lateral collateral ligament, but I won't bother you with that one. We do know that the staple fixation is an issue. We are trying to solve that with different and modern technologies. This is Russian technology again, staple, surgery. We can do it a little bit more elegant, I think, in the coming years. But I like to fix it there, because otherwise you might run into trouble with your lateral tunnel of the ACL. And there's more and more data also with anterolateral ligament reconstructions that there is interference with the ACL reconstruction. So we are still struggling because there's just limited space in that area, and you might cause problems with the other structure, which is the ACL. You can do it isolated, of course. This is, again, this patient with a dysplasia of the knee, previous surgeries, failed ACL, slope that is high. That patient needed something because she was unstable, and so what we did is we just added an ACL, and she's still doing happy. We added the lateral tenodesis, and she still is very happy. There's a lot of debate on anterolateral reconstruction. For those that are a little bit in doubt on what is what, the monoloop is the old one. The anterolateral was recently introduced as being the new solution. But if you look at the vectors and the type of reconstruction, they actually promote the same type of reconstruction, the same vector. The only difference is they fix here on the distal femur, where there is a collision or a potential collision with your ACL reconstruction. And this is the anatomical part, but this is the non-anatomical part, and that's what they all do. So the vector is the same. There's a lot of discussion, but the surgical outcome is just very similar. And this is really promoted by Bertrand Sonnery-Cotter, and I was with Bertrand recently looking into the data, but you see that this one is what we call monoloop, and the other one is ALL. And he does that with the gracilis. We do an ITB strip, and I think the ITB is stronger, more reliable, always there. The gracilis sometimes can be short, and sometimes is 25%. So that means that I think for the ITB is a little bit stronger and more reliable. So we looked into our data. This is the clinical data now. This is also about to have publication. We will present it at ISACOS, looking into our data, 2 to 7 year follow-up, minimal 2-year follow-up. We're doing this for 30 years, but this is the actual data. Most of these patients are done by my senior colleague, Koen Laga. So showing you what we have on 785 patients. For me, that is the most extensive group ever studied in this type of surgery. So the introduction is the same. Let's not go into that detail. Purpose is to report on revision rates of primary anatomical single bundle ACL reconstructions with or without anterope monoloop. This is not a randomized trial. This was at surgeon discretion. We said one patient deserves this, the other patient shouldn't have the monoloop. Let's see what the outcome is. So we have high-risk patient population in the monoloop reconstruction and what we consider to be lower risk patient population in the isolated group. We did the hamstring reconstruction, M4 to M6, with or without the anterope monoloop lateral extra-articular tenodesis, and these were the indications. Surgery is done this way. I showed that previously. We looked at these patients retrospectively. We called them and said, how are you doing? Can you come in, fill out a form? We had 2 surgeons, so Koen and myself operated between 2010 and 2015, minimal follow-up of 2 years, and we needed the full record on file, full file on record, and all patients are contacted by a telephone. Study population, 785 patients, 219 ACL monoloop, 566 isolated. We did a subgroup analysis, and I think the crucial data is in that subgroup analysis, showing age, which recently we identify as being higher risk factors. Young patients have higher risk because they have more anatomical, most likely more anatomical and intrinsic risk factors. Soccer players, high risk overall. Tegner 8, which is high-level athlete, and male-female patient. This is no clear-cut predefined indications. That's where we need to move forward. It's at surgeon's discretion, but therefore we are in this study comparing apples and oranges, high-level athletes versus lower-level athletes. But these data do show a clear tendency. And so we need to further study the effect on the meniscus status, etc. Because we know if your meniscus is out, there is a higher chance for ACL failure. Conclusions is that overall ACL reconstruction with AMLET results in significantly lower revision rates, especially in the less than 25, the competitive athletes and the soccer players. Adding the extra-articular augmentation did not increase complication rates of morbidity. We do see issues with female athletes, and I think that's where we can make some progress. But for me, they clearly support the use of ACL with lateral tenodesis. And this is a tempo we need to work hard in orthopedic surgery. We need to do it faster, stronger, and better than before. And I think we can do that. We can achieve that with the ACL and with the monoloop. So thank you for your attention.